Hello friend, this is Zubair Khan and you are watching Joravi Nursing online classes. Today we are going to see the respiratory systems part 2. So in this video we'll see the other diagnostic test in the respiratory system. So here is next one is pulmonary angiography. So what is pulmonary angiography? It is a fluoroscopic procedure. What is that? Fluoroscopic procedure in which a catheter inserted through the antecubital or femoral vein. So we can insert catheter into antecubital vein or a femoral vein through the antecubital vein or femoral vein into the pulmonary artery. So it will go inside the pulmonary artery or its branches. So we will see the uh, what how blood flow is going on. So via the pulmonary artery we will see the this blood flow. So this is a pulmonary angiography. Okay, so it involves the injection of iodine or radio opaque constant. So we will mainly will use some dye. That dye contains the iodine or another radio opaque substance. It will be a contrast material. So pre-procedure, what we need to do? First we need to assess the patient for any allergies. If he or she is having any allergies to iodine or seafoods or radio opaque dye. If we have some any allergies to iodine, seafood or radio opaque diet, so we need to inform the healthcare provider. Next one is, if patient is going for any procedure like fluoroscopic, we should maintain the NPO status as prescribed. So doctor will prescribe the NPO state, keep the patient on NPO. So we should keep the patient on NPO, and we should assess the coagulation studies like PTINR and all. Okay, so we should assess the PTINR coagulation profile. We need to assess what is the result of the PTINR and establish the IV access. So we should put a large bore cannula like 18 or 16 gauge cannula we should put, because we need to give the iodine dye or other radiopaque substance through that cannula. So we should put the large bore cannula. We can administer the sedation if prescribed. If doctor has prescribed any sedation, so we can administer it. Okay. Next one is instruct the client lie during the procedure. When patient is going for procedure, we should instruct the client he should remain still lie during the procedure. Next one is instruct the client they may feel an urge to cough. So they can feel or he can feel the cough, flushing, nausea or salty taste following injection of the dye. So whatever dye we are giving to the patient, he can feel the cough, we have the flushing fishes and nausea or salty taste also can occur. Okay, so these all the instruction we should give to the client, whoever is going for the fluoroscopic angiography. Next one is have emergency resuscitation equipment available. So whenever patient is going for this radio opaque fluoroscopic angiography, for that we should always keep ready emergency resuscitation equipment. For any other procedure also, whenever we needed, that emergency trolley or crash cart emergency resuscitation equipment should be available near the patient. Then post procedure, what we need to do? So post procedure, there is an important point. What is that important point? So this is the important point. Avoid taking the blood pressure for 24 hours in extremity used for injection. Like whichever extremity, like right hand we have used, right antecubital fossa, antecubital vein we have used for the procedure. So in right hand you should not use for BP. So we should not check the BP from the right hand, or if we have used the left hand, then we should not check the BP by the left hand. Whichever extremity is has been used for the procedure, BP should not be checked by that extremity, whether it is a leg or whether it is a hand. Next important point is monitor peripheral neurovascular status. So like this right hand we are using, so in that, like this is the antecubital fossa, antecubital vein we are using here. So here radial pulse we need to check, like pulse also we need to check, and neurological movements also we need to check, because it may affected that pulse here, pulse can be weak because of due to the bleeding or rupture of the artery or veins, so their blood supply may be cut. Okay, like this is the hand, this is the antecubital vein. So here any rupture can occur or block the blood supply, so this radial pulse will be dull, it can't be felt. And neurovascular, neuro assessment also we need to do, whether he patient is able to move his hand or not. So this is also a responsibility, we should check the neurovascular status. So what we need to check, we need to check the neurovascular status of the affected extremities. Okay, next point is assess insertion site for bleeding, whether the site has any bleeding or any signs of bleeding or any ecchymosis like that. Okay, so we need to check for it. Next one is monitor reaction to the dye. Patient is having any allergy to the dye or anything else. Okay, so any reactions, any inflammatory reaction or any allergic reaction is there due to the dye. Next one is, this is a very important point, and it's our nurse's responsibility, we need to check it. So what is that? That is the apply cold compression to the puncture site to reduce the swelling or discomfort. So whenever we are giving any dye or we are putting a large bore cannula, so there may be a chance of swelling. Okay, so there may be a chance of swelling or intrafiltration and all. So we need to give some cold compress to the patient so he can put on that on the puncture site, so your swellings or discomfort can be reduced. So this is also our responsibility. Okay, so we should put the cold compress to the puncture site to reduce the swelling or discomfort. So this is the fluoroscopic angiography or pulmonary angiography, we can say this is a pulmonary angiography. Next one is thoracentesis. So what is thoracentesis? Thoracentesis is the removal of fluid or air from the pleural space. So when we are going to puncture the pleura and we are going to remove the fluid or air or any blood collection is there, whatever fluid is there, okay, any liquid, blood, pus, so that procedure itself is called thoracentesis. And this, why thora, we can take that out by the transthoracic aspirations. So that is called thoracentesis, and we are taking fluid or air from the pleural space by a transthoracic aspiration. So we will aspirate that blood or fluid or air by that transthoracic aspiration. Okay, thank you. Next one is pre-procedure. So for any procedure, there will be a pre-procedure and post-procedure. What we need to do, what we supposed to do with the client. So that are the things. So prepare the client for ultrasound or chest radiograph if prescribed before the procedure. So okay, if doctor has prescribed for ultrasound or any chest radiograph like X-ray or chest sonography and all, so we need to prepare the patient. Next one is that again coagulation study. I'll say like coagulation studies are whenever we are going to do like we are going to put an incision over the patient, so that time we need to check coagulation profile like PTINR and all. Why? Because we are going to cut patient's skin, we are going to make an incision, so there may be chance of the loss of blood. Okay, so this whenever we are going to put any incision, we need to check the coagulation profile. Next one is note that client is positioned sitting up. So we should make sure patient is in the sitting up right with arms and shoulders supported by a table bedside during the procedure. So like this is the, I'll show you like this one. So he is in sitting position. So this is a table like cardiac table, and he has put all both the arms on the table. Okay, so like this position also we can provide, or this position also we can provide. This is a like slightly lateral recumbent position, and if patient is uh, lie down like a lateral recumbent, we can provide the supine position also. Okay, supine or lateral recumbent position, but best position is this one, sitting positions. Okay, so what is the next point? Next point is client cannot sit up. If client cannot sit up, so this will come like client cannot sit up. The client is placed lying in the bed toward the unaffected side. Whichever side is not affected, patient will lie down on that side with the head of the bed elevated. Like I have shown you, know, this one. So like this is unaffected side, he will be lie down on this side, and this is the propped up position. This is the semi-folus position of the bed. So we need to put the patient in like this position if patient is not able to sit in this position. Okay, so but this is the most favorable position for thoracentesis. Next point is instruct the client not to cough or breathe deeply or move during the procedure. So we should instruct the client not to cough, breathe deeply, or moving the, he should not move during the procedure. Okay. Next one is administer cough suppressant as prescribed before procedure if client has a troublesome cough. If patient is having a cough and all, so SCP will prescribe the cough suppressant. So we should give that cough suppressant before the procedure. Okay, now next point is, so there is, but that is the last pre-procedure what we need to do. Now coming to the post procedure. So what we will do with the post procedure, first thing is monitor respiratory status. So we are going to puncture the lung, so we should always monitor for the respiratory rate or respiratory pattern. Okay, next one is apply pressure dressing. So we should put the dressing, apply a pressure dressing we should put, and assess the puncture site for bleeding and cryptus. So whenever we are going to make an incision or we are going to give some needle, so we should assess for any bleeding signs or cryptus is occurring. Monitor the signs of pneumothorax. So this is a very important. So this is a very important. What we need to do? we need to monitor the client for any signs of pneumothorax, because this is the lungs and we are going to puncture a lung, so there may be chance of the pneumothorax or air embolism. Okay, so there are chance of pneumothorax or air embolism or pulmonary edema. So this is the very important. Okay, this is very important. So there is a sign, we should monitor for a sign of pneumothorax. we should we should monitor the patient for the signs of pneumothorax, air embolism and pulmonary edema. So this is the very important. Okay, next one is review the chest x-ray result to monitor for pneumothorax. So if we think like pneumothorax may occur, so after the procedure we need to uh, do a chest x-ray of a patient and we need to see for the pneumothorax. Okay, now next diagnostic test is pulmonary function test. So what is the pulmonary function test? So in that what we will do, pulmonary function test. Test used to evaluate lung mechanics and gas exchange and acid base disturbance through spirometric measurement. So in this we will see the lung mechanics, how lungs works and how gaseous changes occurs and what is the acid base disturbance will come. Okay, with the help of spirometric measurement. In this, lung volumes and arterial blood gas levels. Okay, and lung volumes also and arterial blood gas levels also we will check. So pre-procedure what we need to do. So determine whether an analgesic that may be depress the respiratory function is being administered. Okay, determine whether an analgesic that may depress the respiratory function is being administered. So we need to check any analgesics have been given or not. Okay, next one is consult the PSCP, primary healthcare provider, regarding withhold the bronchodilators before testing. So if any bronchodilator like Stellene means salbutamol, salbutamol, ipratropium and all is going on. So we need to ask the PSCP like we should hold the bronchodilator before the testing. Before the pulmonary function test, we should hold the bronchodilator if any bronchodilators are prescribed to the patient, or alternatively, or we should give the alternatively like test will be done prior before administering the uh, bronchodilator. We can do the test, or after administration of the bronchodilator after some times. Okay, after some time only we can do the PFT. Okay, so this is the main important points. Next one is the, this is also a very important point. So what is this? This one is very important point. So we need to ask the client to void before the procedure. Okay, we need to ask the client void before the procedure, and he or she should wear loose clothing. Okay, he or she should wear the loose clothing. So this is also very important. Then next one is remove dentures. Okay, so any patient is having dentures and all, so he should remove it. Next one is instruct the client from the refrain from smoking or eating heavy meal for 4 to 6 hours before the test. So we should instruct the client from the refrain from the smoking or eating a heavy meal 4 to 6 hours before the test. Okay. Measure height, weight to determine predictive values. So, okay, so we should measure the his height and weight also. Then next thing is, this is the pre procedure we will do. The next one is pro procedure. So post procedure. Post procedure, what we will do, we will, the client may resume a normal diet. Okay, so he can resume a normal diet, and any bronchodilators or respiratory treatment that were withheld before the procedure. So whatever withhold with the before the procedure, that will be resumed. Okay, now this is the very important point. So this is the very important point. It is here. Client with severe respiratory problems are occasionally exhausted after the testing and will need rest. Okay, so client will severe respiratory problem are occasionally exhausted. So after the respiratory test like PFT and all, the client will be exhausted after the test, and he should take a rest. Okay, so this also we need to teach the client. Now next point is lung biopsy. This is also very important test, diagnostic test, lung biopsy. So what is lung biopsy? A transbronchial biopsy during the, transbronchial means by a bronchi. We will insert a some scope. We will take a needle aspiration, may be performed to obtain tissue for analysis by culture or cytological examination. Okay, so like bronchoscopy we will do, with the help of bronchoscopy we can take a biopsy. So that will be a needle aspiration. Okay, with the help of needle we will aspirate also like two types of biopsy is there. Okay, FNAC also we can do, and with the help of bronchoscopy we can take performed to obtain a tissue analysis for culture and cytological examination. Okay, for culture also it can be sent, and for cell examination, cytological examination means cell examination. Okay, the next point is an open lung biopsy is performed in operative room. Okay, so uh, whenever patient is going for open lung biopsy, it will be in the operative OT only we will do a open lung biopsy. So fine needle aspiration also we can do, or open lung biopsy also we can do, and another with the help of bronchoscopy also we can do the biopsy. Next thing is pre-procedure. So any procedure, there is a pre-procedure. So pre-procedure, what is our responsibility, what is the nurse's responsibility? Like maintain SPO status as prescribed, inform the client with the local anesthetics will be used for needle biopsy, but that a sensation of pressure during needle insertion and aspiration may be felt. Okay, so we should tell the client like, oh, local anesthesia can be give. Okay, and so there will be a needle biopsy, and when putting that needle pressure during the pressure and during the needle insertion, pressure can be felt and the aspiration may be felt. Okay, administer analgesics and sedatives as prescribed, instruct the client remain still during the procedure. So in this also we should tell the patient like he should be still, remain still during the procedure. So what are the things after post procedure we need to do? Apply a dressing to the biopsy site. So we need to put the dressing during that biopsy site. Okay, monitor for drainage or bleeding, monitor for signs of respiratory distress. So any respiratory changes, respiratory patterns is there, respiratory distress is there, so we need to inform the PHCP or SCP. Okay, then again it comes Monitor for the signs of pneumothorax, air emboli. Okay, so pneumothorax is there, air emboli is there. So we need to inform the primary healthcare provider if they occur. Okay. Prepare the client for chest radiography is prescribed. So if doctor asks after the procedure, so we can send the patient for chest X-ray or chest sonography. Okay. So whenever patient is asked for chest radiography, we should send the patient for chest X-ray or any CT thorax and all. Okay. So we will see the signs of any pneumothorax and can be there. Okay. Now next diagnostic test is spiral or helical computed tomography, that is CT scan. So what is that CT scan? As we know, frequently used test to diagnose pulmonary embolism. So CT will be used mainly for pulmonary emboli. Okay. For this only mainly it will be used. So for that we can use sub IV contrast medium. If client cannot have contrast medium, a ventilation perfusion scan will be done. If patient is having any renal impairment, then we will go for the ventilation and perfusion scan. Okay, this scanner rotates around the body. Which scanner? That is CT. This scanner rotates around the body, allowing the three-dimensional picture of the all the regions of the lungs. So like this is the patient is lying down, so it will be going like in spiral manner. So this is the spiral or helical computer gravity. One more CT is there, it will be like conventional CT. So that is a conventional or renal CT. So beam will be going like this. Okay, only one direction, perpendicular direction. So what is VQ scan? Ventilation and perfusion scan. So what is that ventilation and perfusion scan? Perfusion scan evaluates blood flow to the lungs, and ventilation scan determines the patency of the pulmonary airways. So this is the two things. One is ventilation, another one is perfusion. So we'll check the ventilation and perfusion of the lungs with the help of two artificial machines. Okay. A radionuclide may be injected for the procedure. Okay, so there can be a radionuclide will be injected into during the procedure. Generally, this is the preferred test to use with renal impairment. If patient is having renal impairment, means like any kidney disease, or patient have that urea is increased, creatinine is increased, so that time we will go for the VQ test, ventilation and perfusion test. Encourage the client to drink fluids to avoid the renal impairment. We should ask the client drink plenty of fluids. Okay, drink more fluids to avoid renal impairment. So for pre-procedure, what we need to do? We need to assess the client for allergies to dye. Same again, it came like any allergy to dye, iodine or seafood. Remove all the jewelries around the chest area. Review breathing methods that may be required during the test. Establish an IV axis. Then again 18 or 16 gauge cannula we need to put. Okay, so dye easily can be injected into the cannula. Okay, so large bore cannula 18 or 16 gauge we need to put. Administer sedation if prescribed. The patient is uh, not able to lie down. Okay, not able to lie down means patient is irritable and not cooperative, and we can give some sedation if prescribed. Have emergency resuscitation equipment available. Okay, so emergency resuscitation equipment should be available. Post procedure, what we need to do? Monitor the client for reaction to the radionuclide. Okay, so any reaction is occurring, so we need to monitor the client for this. The next one is instruct the client that radionuclide clear from the body about the 8 hours. This is very important. It can come in the MCQ form. So whatever dye or nucleide we are giving, it will come out from the body in a 8 hours. Encourage the client increase fluid intake. So we should ask the client, he should take plenty of oral fluids. Okay, so clear the dye from the body if there is no fluid restriction. So when fluid restriction is not there, we should ask the client to drink more fluids. Then next one is computer tomography pulmonary angiography. What is that? That is CTPA. So what is that? That is CTPA. So this is a CTPA. It is called CTPA. So the scan visualize the pulmonary arteries and blood flow. So in this we will see the pulmonary arteries and blood flow in the pulmonary arteries. It main used in diagnose pulmonary embolism. So mainly it is used for diagnosing the pulmonary embolism, and it is preferred method. So CTPA is the preferred method for pulmonary to diagnose the pulmonary embolism. A contrast dye is injected. Contrast dye is injected. Okay, in this also we will inject some dye. Procedure similar to VQ lung scan. In addition, renal function should be adequate. Okay, so in this also renal function should be adequate. So then only we can go for CTPA. Dosing of contrast should be done by a pharmacist. So how much dose should be given? So it will be inquired by the pharmacist. So he will explain, he will tell the dose of the dye or contrast. So that will be given by the radio people. Okay. Then post procedure. So what is the post procedure? It is a similar like VQ lung scan what we see, similar to the that only. We need to check for any allergies and all. Okay. Then skin test. Skin test. What are the skin test? Skin diagnostic test we do. Okay. So these are the tests. Skin test is skin test use intradermal injection. So we use intradermal injection. Okay, to help diagnose the various infectious disease. Like for TB, we do tuberculin test. Okay. Next one is ABG. So this is a very important point. Okay. So what is ABG? This is the arterial blood gases. So we will take sample from the arteries and we will measure the oxygen or carbon dioxide into the blood gases. So which indicates the acid base balance. Okay. So in that we will see the pH, bicarbonate, PO2 and PCO2. So we will see the respiratory acidosis or respiratory alkalosis or metabolic acidosis or metabolic alkalosis. So pre-procedure, post-procedure care and result and analysis. These all things we will see in the chapter 9 about the when we will discuss about the ABG. Okay. Now very important point related with the ABG. So this is the very important point. So whichever this red one is there, no, this red one, so that is a very important. That is a question for that is our MCQ. Okay. So what is the question is here? Avoid suctioning the client before drawing an ABG sample because suctioning procedure will deplete the client's oxygen and resulting in inaccurate ABG. So whenever we are going to take ABG, so avoid suctioning. We should not do the suction of the client before drawing the ABG, because it will, what it will do, it will deplete the client's oxygen. So okay, oxygen will be less into the blood, so accurate ABG will not come. It will be a false ABG. Okay, so next is pulse oximetry. So pulse oximetry, you know, we will measure the SpO2 and all. Okay, now next one is D-dimer test. So what is D-dimer test? So this is also important. This is a blood test, measure the clot formation, and the lysis result is from the degradation of the fibrin. So it is a blood test which measures the clot formation. Okay, what does it measure? It measures the clot formation and help to diagnose a positive test result, the presence of thrombus. Okay, so it helps to diagnose the presence of thrombus such as deep vein thrombosis. So in DVT it can be there. Okay, DVT and PE, pulmonary embolism or stroke. So for stroke also we do, and stroke, STROK. Okay, so stroke, pulmonary embolism. Okay, so it is used to diagnose disseminated intravascular coagulations. For DIC also we use it, and to monitor the effectiveness of treatment. So if we are giving some some treatment, antiplatelet drugs, okay, like antiplatelet, like aspirin and all, clopidogrel we are giving. So for that effectiveness is there about the treatment. So that also we'll check with the D-dimer test. The next point is D-dimer has high sensitivity. It has a high sensitivity and low specificity for diagnosing clot formation. The normal D-dimer level is less than 50 nanogram per ml, less than 3.3 millimole per liter. On normal fibrinogen is 60 to 100 milligram per deciliter or 2 to 5 gram per liter. Now coming to respiratory treatments. So this we will study in next chapter, that is chapter 70. Before coming to, this is the clinical condition, chest injury and all. You will see here this tuberculin test. So what it says, this tuberculin test, we will see. Tuberculin test procedure. So first we need to determine the hypersensitivity. So okay, or any previous reaction to the skin. So any allergic reaction is any allergy about this test, we need to ask the patient. Okay, we need to ask the client. Next one is the assess the client has received BCG. If patient has received BCG, then this tuberculin test will be, it will come positive, which would demonstrate a positive reaction. Okay, use a skin site that is free from excessive blood, body hair or any dermatitis and blemishes. So we should use the skin free from any body, like it should be smooth and clear. No body hair, no dermatitis and all should be there. Then next one is apply injection at the upper third of inner surface of the left arm. Upper third of the inner surface. Upper third inner surface of the left arm. So where we should apply it is upper third inner surface of the left arm. Then next, circle. We should put a circle. We should put a circle and mark the injection test site with indelible ink. Okay, so with indelible ink we should mark the circle, and we should put a circle and mark the injection site. Then we should document the date, time and test site. The next point is advise the client not to scratch the test site to prevent infection. So we should ask the client, we should not scratch it, and possible abscess formation. So if we will scratch it, it will go for a infection or abscess can be formed. Next point is instruct the client avoid washing the test site. So we should instruct the client. What we should instruct the client? Instruct the client avoid washing the test sites. So wherever we have done the test, we should not wash it. And assess the reaction of injection site 48 to 72 hours. So for any reaction will occur within the 42 and 48 to 72 hours after administration of test antigen. Okay, so when we administer the test antigen within the 48 to 72 hours, that reaction will occur. Assess test sites for amount of induration, heart swelling in mm, for the presence of erythema and vesiculation. A small blister like elevation will be there. So we should check the diameter and all. Okay. So these are the tuberculin tests we need to do it. Now coming to the disease condition, this is the most important things. So whatever is we have read till now, that is also important. But this now topic has started. This is the main respiratory problems we need to see. Rib fracture. So this is very important. Rib fracture. How rib fracture can occur? So result from the direct blunt chest trauma. So this is the chest. If any sharp object it penetrate the lungs, so that rib fracture can be occur. So direct blunt trauma. Okay. So it can be a blunt trauma and causes a potential intrathoracic injury such as pneumothorax. So anything hit to the lungs or chest, then the fracture will be can be occur. Okay, so which can lead to the pneumothorax or hemothorax or pulmonary contusion can be occur. Okay, due to the this blunt chest trauma. Then next point is when chest trauma is occurring, what can be there? Chest injury is there. Pain with movement. When we move, pain will be there. Deep breathing we do, pain will be there. If we cough, pain will be there. Result in impaired ventilation, and ventilation will be impaired. And inadequate clearance of secretions. Okay, this can be a serious. So it is a very serious or life-threatening condition. It is a very serious and life-threatening condition. When three or more ribs are fractured, when three or more ribs are fractured with pre-existing disease like particularly cardiopulmonary disease or for elderly client. So it can be a very serious if patient is suffering from any cardiopulmonary disease or patient is elderly. Okay, any pre-existing disease is there, so it is a very serious condition, that is rib fracture. Now assessment, what we will do, what we will assess. So we need to assess for the pain and tenderness at the injury site. So the main thing is pain. Okay. injury site that increases with the inspiration. When patient inspire, pain will be increases and tenderness will be increases. Then we should check for the shallow respiration. This also important point. It comes in the MCQ. It comes in the MCQ. Shallow respiration. The next point is client splints chest using a plow as needed. Then client splints chest using a plow as needed. External splints are not recommended because they limit the chest wall expansion. So for client chest injury, we should provide a pillow. So a pillow can be used like a splint. External splints we should not give the patient because it will limit the chest wall expansion. If we are giving another like different types of splint to support the chest, so then it will inhibit the chest wall expansion. Okay, now what are the interventions we need to do? Okay, we will see the interventions. Note that ribs usually reunit spontaneously. So we need to note that ribs usually reunit spontaneously, and client has a higher risk of developing pneumonia after rib fracture. So this is a very important point. Client has a higher risk for developing pneumonia. Okay, so client have a higher risk for developing pneumonia after rib fracture. Open reduction. Okay, open reduction and internal fixation of the rib plating may be done. So what we can do? Open reduction we can do and internal fixation we can do with the rib. Place of place the client in Fowler's position. So this is very important. So whenever any respiratory problems comes, any respiratory things, we should provide the Fowler's position to the patient, semi-Fowler's, Fowler's or high Fowler's. Then administer pain medication as prescribed. Maintain adequate ventilatory status. Monitor for increased respiratory distress. So we should monitor for the any respiratory distress has increased. Instruct the client to self-splint with the hand, arms or pillow. So we can instruct the client, he can put any hand or arm or pillow to put a like self-splint. Okay. Prepare the client Prepare the client for intercostal nerve block if prescribed if the pain is severe. When pain is not relieving by the painkillers, okay, so then nerve block can be done. Okay, so this is the rib fracture. Now coming to next heading is flail chest. So this is also very important topic, flail chest. So what is flail chest? It occurs from blunt chest trauma. When blunt chest trauma occurs, it, it will lead to flail chest with the accidents which may result into hemothorax and rib fracture. Occurs from the blunt chest trauma associated with the accidents which may result into hemothorax and rib fracture. The loose segment of chest wall becomes a paradoxical to expansion and contraction of the rest chest wall. So there will be, we used to say no, paradoxical respiration will be there. Okay. The loose segment of chest wall becomes a paradoxical expansion. So that chest wall will become a paradoxical to the expansion and contraction of the rest of this chest wall. Then other chest wall will be contracted. So this is very important. What we will see? In assessment we will see the paradoxical respiration. So this is very important. In Flail charts, paradoxical respiration will be there. What is paradoxical respiration? Inward movement of a segment of the thorax during inspiration with outward movement during expiration. So when we inspire, inward movement will be there of the thorax. Okay. Usually we inspire, outward movement will be there. Okay. But in paradoxical respiration, in inspiration time, inward movement will be there, and outward movement when we expire the when we do expiration, it will be outward movement. Then severe chest pain in the chest. Okay. Severe chest pain. Then dyspnea. So patient can be dyspneic and cyanosis can occur. Then tachycardia can occur. Then hypotension can occur. So these all four are very important. DCTH, DCTH, dyspnea, cyanosis, tachycardia, and hypotension. And one more T is tachypnea. One more T is tachypnea. DCTHT. Okay. Dyspnea, cyanosis, tachycardia, hypotension, and tachypnea. Okay. Then shallow respiration. Shallow respiration is also there. Okay. But most important, paradoxical respiration is a unique feature of this Flail chest. Then diminished breath sound. So breath sound will be diminished. It will be decreased. Then next thing is intervention. So what are the intervention for this type of client? Provide the Fowler's positions if cervical spine injury has been ruled out. Okay. If cervical injury is not there, then we can provide the Fowler's positions. The next important thing is administer the what? O2. We should administer the O2 oxygen. Okay. Monitor the increased respiratory distress. We should monitor the patient whether respiratory distress has been increased or it has been decreased, whatever. Okay. Increase the coughing and deep breathing exercises. So we should ask the patient cough or do the deep breathing. Okay. And administer pain medication as prescribed. Maintain bed rest and limit the activity to reduce the oxygen demand. We should ask the patient limit his or her activity, otherwise oxygen demand will increase. Okay. The next point is open reduction and internal fixation of the plating may be there. So this we can do in rib fracture also. It was this point was there. Okay. Prepare for intubation. This is also very important point. So we should prepare the patient for intubation with a mechanical ventilation with positive and expiratory pressure, that is a PEEP, for severe flail chest associated with the respiratory failure and shock. Okay. So we should always keep ready the intubation trolley. Okay. Then it is enough for today. We will see other things in next topic, in next class. Okay. In next class we will see the other topics. Okay. So thank you all of you. Read it and study well and do hard work. Okay. So in next class we will study the pulmonary contusion and other topics also. Thank you all of you. Thank you very much.